Thank you very much. Thank you for inviting me. I hope this doesn't cause me problems. It seems that the slideshow is moving along automatically at times, which I'm going to try and stop happening. But I'd like to talk about some of the sacred cows in clinical trials, things such as randomization, double-blind placebo-controlled trials, the importance of all-cause mortality, pragmatic evaluation of intended use, and informed consent. And I like a quote which is sometimes attributed to Pablo Picasso, although whether he really said it or not, I don't know, which is that you should learn the rules like a pro so that you can break them like an artist. And I guess that's the theme of my talk. So I'll start with randomization. And why do we randomize? So randomization goes back much further, but the essence of it is in order to be able to infer causality. And if we look at Judea Pearl's do operator, the theory is that he wants to know what happens when you force X to take on the value X. So when you force the treatment to be a particular treatment. And how do we force that? Because if we observe it in the general population, the problem is that the people who take a particular treatment may be sicker or healthier than the people who take a different treatment. So we randomize people to different treatments. When we're evaluating a diagnostic test, there's no need to randomize. The simplest thing to do and the best thing to do is to do both tests. There's no bias, and the reason is because there's no causality. Do test A is no different from C test A. The patient either has or has not got a particular pathology, and testing doesn't change that. So finding out what both tests would have said for that individual is much better than randomizing individuals between two tests. And an example of this is from HPV testing and comparing it to cervical cytology for the detection of high-grade CIN. And this is indeed what virtually all the early studies of HPV testing did. They did both HPV testing and cytology, mostly on the same sample or on two samples taken at the same time from women. And a number of studies we put together, including over 60,000 women. And we found very clear results that the HPV test found 96% of the women who had high-grade CIN compared to 53% for cytology. So much better at detecting high-grade CIN, but it came at a price, and that price was that rather than having 4% of women who didn't have high-grade CIN testing positive on cytology, that increased to 9%. And using this split sample approach where you give both tests to everyone can have a dramatic result on the size of the study that you need to do. And so this is an example like high-grade CIN. We assume about 1 in 200 of the population have the disease you're interested in, and both tests will assume have the same specificity, 97%. And we assume that our new test, we want to show if it's better when we think it might be 90% sensitive compared to 80%. If you did a randomized controlled trial, you'd need 700,000 people to take part. But if you do this split sample design with some assumption about how similar the two tests are, then you would need 63,000. So less than 1/10 of the numbers. And that's a huge difference. But if we're doing screening, it's slightly different because it's not enough to diagnose a certain pathology. The point of screening is to then to intervene to prevent some further bad outcome. In cancer screening, that's mostly intervening to prevent death from cancer, but sometimes it's intervening to prevent cancer occurring if we found a precursor condition. And so in that sense, it may be necessary to randomize between screening and no screening. And that's exactly what happened with HPV testing and cytology. Once it had been shown that HPV testing was much more sensitive, the question was, would it lead to a greater prevention of cervical cancer? And no study that was done, none of the randomized controls were large enough on their own to look at cervical cancer, but pooling 4 randomized controlled studies were a total of 107 cervical cancers that had happened. And you can see some quite dramatic results that over 8 years, there was 40% less cervical cancer in those who were screened by HPV testing compared to those who were screened by cytology. And in fact, it's even more impressive because in the first 2.5 years, basically those were cancers which were present but had been diagnosed at the time of randomization. And once those have cleared out, the curves separate much more, and there's a much bigger difference. And so we're applying that to a grant that we've put in to study a device called a Cytospinach, invented by my colleague Rebecca Fitzgerald in Cambridge. It consists of a sponge on a thread, and the sponge is compressed into a gelatin capsule, the same size as an antibiotic pill. So the patient swallows the sponge with a glass of water, with the nurse holding onto the thread. And after a few minutes, to give the gelatin time to dissolve, the nurse pulls out the sponge. It's much more acceptable than it sounds.
Yeah,
You can hear me? So there are two applications of this. We could either look at the sponge in a screening setting, and that's what we want to do, a randomized controlled trial, to see whether by offering this test to people who have esophageal reflux, gastric esophageal reflux, we can actually find disease, intervene, and prevent death from esophageal cancer. And that will be a randomized controlled trial. But there's also a group of people who have regular surveillance, endoscopy every 2 or 3 years, because it's already known that they have some precursor condition. And there we don't need to do a randomized controlled trial. We just simply use the Cytospinach together with endoscopy every time endoscopy is done. So I'm sorry that these slides have a mind of their own, but I want to talk about blinding as the second sacred cow. The rationale for blinding is that human judgment and behavior is influenced by knowledge. So there are two things that we do in clinical trials. One, which I think always has to be done, which is allocation of the concealment of the allocation, so that the treatment is not revealed until the patient has already been entered into the trial. And without this, randomization is pointless, because someone would say, oh, well, what treatment am I going to have? I'd rather not be in the trial if I'm going to be in the control arm. So we wouldn't have a true randomized comparison. And the second thing is blinding, which is keeping people unaware of the allocated treatment. And it's used to eliminate bias resulting from the knowledge of what treatment is happening. It's particularly important when the response is subjective, less so for objective response, such as death. Patients are blinded so they don't change their behavior, and clinicians are blinded to minimize the bias in the patient management and their interpretation of whether the patient is making progress or not. A few years ago, I was doing a trial where there was a disagreement between the statisticians, myself and Julian Pito, and the clinicians, Adrian Martineau and Erwin Nazareth, about whether we should have a placebo-controlled trial or not. This was a trial of vitamin D supplementation in the elderly, hoping that it would actually have an impact on all-cause mortality. And because of the disagreement, we agreed that we could study whether or not it was a good idea to have a placebo-controlled trial. So individual patients were randomized to either vitamin D or no vitamin D. But we randomized GP practices to either having an open label study or a placebo-controlled trial. And there were 10 practices in each arm. And I think the results are quite telling. In terms of participation, 15% of the people we asked to participate, we offered in the open practices, agreed to take part, compared to 13.4% in the blinded practices. In terms of compliance, 91% compared to 89% were still taking their drops at 2 years. In terms of contamination, we were looking at the proportion of people who were taking extra vitamin D supplementation that they were buying over the counter. And that was 5% in the open practices and 4.8% in the blinded practices. And if we looked at the vitamin D concentration in the blood at the end of the trial, and what proportion of participants had what we consider to be sufficient vitamin D, it was 19% versus 17% of the controls, and 87% versus 89% amongst those who had been randomized to vitamin D. So blinding made virtually no difference to all these measures that we would be hoping to affect by doing blinding. And my view and Julian's view is that this showed that actually there was no need to do blinding, and placebo control adds hugely to the cost and complication of doing a clinical trial. So an example of a trial that we're about to start is called FINESSE, and this is a trial sponsored by, funded by Yorkshire Cancer Research. So many men on active surveillance for early or intermediate prostate cancer opt to have radical treatment without having true disease progression. So series show that over half of men who start out on active surveillance have radical treatment within 15 years. And many times that's because they become anxious about leaving a cancer untreated, as it were. So we have a drug called finasteride, which we think will both have a biological and a psychological effect. So we want to do an open label randomized controlled trial of active surveillance alone versus active surveillance plus finasteride. And there's three reasons why we're not going to use placebo. The first is because finasteride decreases PSA levels. It's well known to do this, particularly in a benign disease. And so since PSA is monitored in men with prostate cancer, it will be kind of obvious which arm most men are in by looking at their PSA test results. The second is that finasteride is off patent. There's no placebo. We would have to manufacture a placebo specially. We'd then have to package it and label it. And that is extremely expensive. We think it would double the cost of the study if we had to have placebo. And finally, and most importantly scientifically, because we're both interested in the biological and the psychological effects of the drug, if we blinded patients, we would remove any psychological benefit that there might be. So here I'm quoting from Sir Rory Collins, who wants to emphasize the importance of having unbiased ascertainment of the major outcomes. And he's saying that missing data actually has little impact if it's unbiased with respect to allocation. So it's putting huge amounts of effort into getting rid of missing data is probably not a great idea. He's also shown that if you do adjudication of study outcome, it adds substantial costs, but typically little gain. In most studies, it makes very little difference. So you need to put much greater reliance on comparisons with the randomly allocated control group and to make sure that's working. So this is an example of where we tried to follow that. So this is the Cytospinach again, and this was the earlier study where we demonstrated that the Cytospinach was actually really good for detecting Barrett's esophagus. So it was an open label randomized controlled trial, and the primary outcome was the diagnosis of Barrett's esophagus within 12 months of randomization. Now, there was going to be a problem with that, because if someone was randomized to the Cytospinach test, if they had a positive test, they would then get referred to endoscopy, and that endoscopy would likely take place in the same hospitals. And so the team would know this patient had had a positive Cytospinach result, they were in the study, and we would be pretty certain of knowing about that Barrett's esophagus diagnosis. Whereas someone who wasn't randomized to the Cytospinach, sometimes later they go off to a hospital which may be slightly outside of the area of the study, have endoscopy, and Barrett's esophagus is diagnosed, but the GP may never enter that result in their records. So we decided we're not going to use every Barrett's esophagus we know about. Instead, we did the same identical searches of the medical records of those people in both arms. And we only used Barrett's esophagus that was found through those systematic searches and then confirmed. And pleased to say there was only one Barrett's esophagus that we knew about that we couldn't include in the study that way. But it meant that we had much greater confidence in the results, that this wasn't just a question of knowing about all the cases of Barrett's esophagus in one arm and not knowing about them in others. This really was all those that were recorded through endoscopy departments or in GP records. So I know that one of the topics that people in Concilium are interested in is all-cause mortality, and it's been quite a controversial issue, and I like to think that this article was published on Fireworks Day in 2011, and it was a debate in the BMJ on should we use total mortality rather than cancer-specific mortality to judge cancer-specific cancer screening programs. And James Penston wrote yes. And he had three basic arguments. First of all, the cause of death is unreliable. And to that I say, that's true, but it's good enough. Going back to what Rory Collins said, in virtually all places where you do randomized controlled trials of screening, cause of death is recorded pretty well. And if it's not, you can always use excess mortality, which is far better, I would argue, than all-cause mortality. The second argument he had was that disease-specific mortality ignores the fact that screening for cancer causes harm. And I would say that we do indeed need to measure the benefits and harms, but we need to measure them separately and then put them together to assess the overall impact through modeling. And finally, James Penson said that invasive procedures may have fatal complications. And this is true, they're very rare, but looking at all-cause mortality will miss them. You will not know if you're causing those problems. And so 6 years later, I wrote an article with Sir Nicholas Ward in which we argued that all-cause mortality is a really bad endpoint when assessing disease prevention or early detection. And we had three basic arguments. First of all, it is too blunt an instrument, too crude a measure of either benefit or harm. The results are dominated by causes of death, which are totally unrelated to the intervention. And one of the consequences of that is that it would require huge numbers of patients to show efficacy in terms of all-cause mortality, even when there is a highly significant effect on cause-specific mortality. And so in this example where the intervention is preventing 70% of deaths from cause X, and cause X is responsible for 5% of all deaths, then I'd estimate that we need 41,000 people to do a randomized controlled trial where cause-specific death is of interest, and over 1 million people if you want to look at all-cause mortality. So it's more than 25 times as many. And if you look at the recovery trial, they have managed to study 9 different interventions since COVID-19 started. 3 of them were found to work, 6 of them have been shown not to work. If you had used something as crude as this, we'd still be waiting for the results of the first test. Requiring studies to be too large does cost lives. Using all-cause mortality, I argue, would actually slow progress. Hpv immunization was introduced in 2007 in some countries, in 2008 in the UK. It's led to dramatic reductions in HPV infections and is the basis of the WHO's strategy for elimination of cervical cancer. Trials of HPV vaccination have not yet shown a reduction in cervical cancer mortality. They haven't even shown a reduction in cervical cancer incidence. Had we required a reduction in all-cause mortality, we would still be far from licensing a vaccine. A whole generation of women would have lost out. But what's more, no company would ever have invested in HPV vaccine development. I think that requiring a significant reduction in all-cause mortality in clinical trials would prevent virtually all public health advances, and it would be a retrograde step. The other argument that I posed with Nick Ward is that interventions aimed at preventing death from X that increased mortality from another cause Y. So in this case, if you take the argument of all-cause mortality to its logical conclusion, you would have to continue a study even when it's clear that it's futile. So this intervention was designed to reduce mortality from cause X. What we see here is that actually there were more deaths, 124 versus 103, in the intervention arm than the control arm for cause X. And at best, the 95% confidence interval says it might result in an 8% reduction in death from cause X. I would say this is a null result. You should stop the study and give up with the intervention. But if you look to all-cause mortality, in this example, there's been a 3% reduction in all-cause mortality, and it's possible that the intervention could lead to a 9% reduction in all-cause mortality. That would be huge. If you believe it, even though you've already randomized 150,000 people and said no effect where you believe there should be effect, you would need to continue because there could still be a dramatic effect on all-cause mortality. I don't think anyone would do that, but it shows that people don't really believe that they should be using all-cause mortality as the endpoint. And then it's not generalizable. the impact of an intervention on all deaths depends on the underlying risk of those diseases that it affects, and it's likely to be very different in different populations. An extreme example is where an intervention helps to reduce one cause, disorder A, by 30%, hazard ratio of 0.7, and it increases another disorder, disorder B, doubling. If you take a population where both disorders are reasonably common, in this example, the overall effect is a very slight increase in death, 5 overall. But if you go to a population where disorder A is very common, so you've targeted your intervention to people who are at high risk of what you believe is going to be, and you've excluded people who are at high risk of disorder B, then you might get a very different situation. And here you're resulting in 550 fewer deaths overall. But that means that if you did your main study in population 1, you would conclude that the intervention was useless. And so people in population 2 would never benefit. And if you did your study in population 2, which is in fact more likely, you would have found that overall there's a reduction in all-cause mortality, and you might think you can use that in population 1 too. And actually that would be a big mistake, because you would have missed that you're also causing a slight increase in disorder B, and when disorder B is more common, that would be fatal. So Nick and I said that evidence-based medicine should not be about withholding interventions until they have been proven to reduce overall mortality. It should be analytic and intelligent, assessing the efficacy and the harms of an intervention separately, and then applying these estimates to populations that might be offered the intervention effect on all-cause mortality. And in fact, if we look at how surrogate endpoints work for all-cause mortality, they actually tend to be pretty good. So this is a plot looking at the observed all-cause mortality in trials of cancer screening. And each point on this is from a meta-analysis. So these are all the randomized controlled trials of that type of screening. And it's plotted against what you would expect the hazard ratio to be if you have the observed effect on cancer-specific mortality and no effect on any other. And you can see there is an extremely close correlation, very close to a straight line. The average effect on all-cause mortality is exactly what one would expect if there'd been no off-target effects. And that line is going through the origin, and it has slope 1. Seeing how this plays out, Nelson was a randomized controlled trial of low-dose CT screening for lung cancer screening. Recruitment was through population-based registries. It was randomized CT screening versus no screening. They had central reading of CT images. They had an expert committee looking at the cause of death, and the follow-up was through national cancer registries. At 10 years, these were the results. There was a significant reduction in lung cancer mortality, pretty much as anticipated. They were powered for a 25% reduction in lung cancer mortality. There was no effect on all-cause mortality. And if you had used advanced stage lung cancer as your endpoint, you would have got results very similar to those using lung cancer mortality. If we look at breast screening trials, there is a very tight relationship between the relative risk of breast cancer mortality and the relative risk of advanced breast cancer, as shown in this plot. So the greater the reduction in the risk of advanced breast cancer, the greater the mortality reduction. And the only trial that found no benefit of breast screening on breast cancer mortality was also the only trial to find no benefit in terms of advanced breast cancer, a reduction in advanced breast cancer. When designing studies of screening, it's very important to think about the duration of screening and the duration of follow-up, and these have big effects. So here, this is the European randomized trial of screening for prostate cancer, and looking at results at 9 years and at 16 years. It was a multi-center trial. What they did in different countries was slightly different. But in terms of the incidence rate ratio. At 9 years, it was 1.9, hugely more cancers found in people that you screen. And at 16 years, it had reduced to 1.4. But even more so, if you look at the number of extra cancers, that had reduced too. It was down from 39 per 1,000, I think it is, to 31. And the mortality rate ratio had actually improved slightly. It went from 0.84 to 0.81, but particularly the difference, there was only 0.5% less death from prostate cancer at 9 years, whereas there's 1.8%, so an extra 1.3% of all men in the trial had avoided dying from prostate cancer. So with longer follow-up in this case, the harms decrease and the benefits increase. And in the UK age trial of breast screening, this offered annual screening from age 40 to 47 plus routine screening from age 50 in one arm versus routine screening from age 50 only in the other arm. So one group you started screening from 40 and the other from age 50, and there were no screens between the ages of 47 and 50 in either arm. And the primary analysis was to be at 10 years, and there was a secondary analysis at a median of 23 years after people were randomized, when they were randomized. So in terms of breast cancer mortality, the deaths within 10 years of randomization, the relative risk was 0.75, and that was just significant. At 23 years, if we looked at all cancers diagnosed up to and including the first routine screen, the relative risk was 0.86. So it had become less good, and it was no longer significant, just. But if we looked at deaths beyond 10 years, then actually the relative risk is 0.98. So what is going on is that the benefits are diluted. They're not decreased. It's not that the people were dying more after 10 years. It's just that since it was no longer making any difference, if you include those deaths with the deaths that could be affected by screening, that's why you're seeing a dilution of the effect. And one extreme proposal for looking at screening is to do a single screen versus no screening. And this is sometimes attributed to Nick Wald. The advantages are that it minimizes the number of screens that you will require to do for a fully powered study. It provides data to inform the most appropriate screening interval because you can see how risk changes over time after that single screen. And there's no issues with long-term compliance in the screening arm because you're only asking people to be screened once. The disadvantage is it only studies the prevalent screen, and we know from several screening programs that there's a big difference between what happens on a prevalent screen and on subsequent screens. It underestimates the potential benefit of doing regular screening, and it provides no data on the cumulative sensitivity and specificity of sequential screening. We generally think that if you were screen somebody the next day, you'd get the same wrong result. And so you need to see what happens over time. So I'd now like to talk about efficacy and effectiveness. Efficacy or explanatory trials determine whether an intervention produces the expected result under ideal circumstances. Effectiveness or pragmatic trials measure the degree of beneficial effect under real-world clinical settings. And I would argue that there's no point in trying to show effectiveness before you have established efficacy. It is important to look at effectiveness. We can't do everything under ideal circumstances. We have to do it under real-world conditions. But there's no point in investing in a huge pragmatic trial if you don't know that the thing you're interested in can work under ideal conditions. And efficacy is like do X in Pearl's language, whereas effectiveness is looking at what happens when you offer X. This is the comparison of those two things on the European prostate cancer, looking at results at 9 years. Doing the intention to screen analysis, those randomized to the offer of screening versus those randomized to not, the relative risk was 0.8. If you adjust for non-attendance, it becomes 0.73. And if you both adjust for non-attendance and compliance, by which we mean looking at who had PSA testing in the control arm, then it becomes 0.69. And the confidence interval is slightly wider too. So the bottom line is that the effect of the invitation is a 20% reduction in prostate cancer mortality within 9 years of randomization. But the actual causal effect of PSA testing is a 31% reduction. In the CAP trial, which was the UK trial of prostate screening, this was a cluster randomized trial with a Zellin design. So because it was clusterized, even though it was 1-to-1, the numbers in each arm weren't exactly the same, but it was about 200,000 men in each arm. The problem was, because of the way it was done, only 36% of men in the intervention arm had PSA testing. And we don't know for certain, but the authors estimated that between 10 and 15% of men in the control arm had at least one PSA test over the 10 years of the intervention of the study. And the results were that there were 549 deaths in the intervention arm and 647 deaths from prostate cancer in the control arm. And the ITT analysis, the effectiveness analysis, was a relative risk of 0.96. And at best, you had a 15% reduction. And so the authors concluded that there was no point in doing prostate screening. It didn't work. But in fact, if you do the efficacy analysis, which the authors did, the confidence interval for the relative risk is 0.67. So it's possible that the causal effect of PSA screening is a 33% reduction in prostate cancer mortality. So the problem caused by non-compliance and contamination is that it dramatically reduces the power. And so in an example like that, where if we assumed that the causal effect is to reduce mortality from 300 to 200 per 100,000 people, if you had 100% compliance with the randomization, you would only need 50,000 men per arm to have a well-powered study. Whereas with 35% compliance with the offer and 10% contamination, you'd need 930,000 men in each arm, which suggests that CAP was seriously underpowered. It had less than a quarter of those numbers. And that's the problem with doing pragmatic trials before you're agreed on whether the efficacy is there or not. So one of the designs that you can use to improve compliance is what I call concealed versus revealed designs. And the idea is quite simple, that you test everyone, but you only tell those randomized to the intervention the results of the test. This guarantees 100% compliance, but it's questionably in terms of the ethics. But it was done in the artistic trial of HPV testing and primary screening. And the reason, what happened was everyone got both cytology and HPV testing. And in one arm, they were only told about the cytology results, and that's how they were managed. And in the other arm, they were told about both test results. It was felt to be ethical because cytology was the standard screening program, and both tests were done on the same sample. But is it ethical to ignore the test result? So the question is, would it have been better not to do the HPV test, but actually to store the sample? And you can always do the HPV test later. I think it would be more ethical, and it certainly saves money in not having to do lots of tests which you're not going to look at. And that's what was done essentially in the UK CTOX ovarian cancer screening trial. They invited nearly 1.25 million women, and they actually enrolled 200,000 women. And the ones they enrolled were the ones who turned up to a recruitment clinic. And they only randomized those that turned up to the clinic, and they randomized them essentially 50,000 to each of 2 different screening arms and 100,000 to no screening. So the problems with this design is, if you only get 200,000 people out of 1.25 who you've selected, is it representative of the population? So it's not an effectiveness trial. It's only really looking at efficacy. There's also a question that 100,000 women attended a recruitment clinic, provided a blood sample, but had no screening. Is that okay? They'd all consented to it. I think it probably is. But it meant that 99% of those in the multimodal arm, who essentially were going to have a CA125 test on blood, and 95% of those who needed to have ultrasound were actually screened. So it was a very efficient design. You can actually increase the efficiency dramatically if you change the analysis. And so what you want to do is look at everyone who dies from the specified cancer and had a positive test result at baseline, say. And the argument is that screening only makes a difference in those who test positive. Nothing changes for the people who test negative. So the design enables one to look only at those who test positive, because we know in both arms who test positive, to see whether acting on that would make a difference. So you can go and retrospectively, if you like, test all the samples from those people that die from the specified cancer during the follow-up to look at their baseline test if they were in the control arm. And then you can say, were there fewer deaths in the group where you knew the result and you acted upon it than in the group where you didn't know the result and therefore you didn't act upon it. And you can use the same sort of argument to look at harms of screening. So were there more deaths from other causes amongst those who tested positive and we knew about the positive result than amongst those who tested positive and you didn't? And was there overdiagnosis in terms of those who tested positive and you acted on it compared to those who tested positive and you didn't know about it? And the sample size of doing this analysis, again, is a dramatic reduction. So here's the example, about 3 per 1,000 men would die from prostate cancer. If we assume half of them would have been picked up by the PSA test, acting on that PSA test reduces mortality by 2/3. So if that's what's going on, you'd essentially need to get 38 PSA positive prostate cancer deaths in your study, which would mean 19,000 men per arm, which is much smaller, as I'll show you later. Another way of doing it is only revealing the results in the intervention arm to those who screen positive. In that way, most participants will be blinded as to which arm they are in. So if we had not told the men who had a negative PSA test that they'd had a negative PSA test, we would have got something that was much more like a blinded study. So to sum up, in terms of this prostate screening, if you did a randomized controlled trial, pragmatic, you'd need 930,000 men per arm. That's the CAP trial. If you did something like UK CTOX, randomizing at the clinic, you could reduce that to 50,000 men per arm. And if you take advantage of the concealed versus revealed, you could reduce it to 19,000 men. So these are huge differences. If you want to talk about efficient clinical trials, you need to think about the design. Randomization is really important. Real world data is not the answer to doing efficient designs. It's thinking about what the problem is and how to design your study to answer that problem with precision. And so I can tell you a little bit about the Nhs Scholarly Trial, which we hope to start in a few months. It is a big trial in partnership between Grail and NHS England, and it's being run through my clinical trials unit, the Cancer Prevention Trials Unit at King's College London. We will be randomizing. It's randomized. It's going to be, we're only randomizing after the blood has been taken. So it's a concealed versus revealed design, but we're only going to test up front those people who are in the reveal arm. The others will be stored. It's double blinded, and we only unblind if the test is positive in the screening arm. The duration of the screening will be 3 annual screens, so 2 years is the duration of the screening period. And the follow-up will be for a further 1 to 2 years. So it's a minimum of 1 year follow-up after the last blood draw but everyone, we hope to recruit the people in a year. So that's how it's going on. And the primary endpoint is the cumulative incidence of advanced cancer. And we're using that because we get a readout at least a year and probably more like 2.5 years earlier than if we had to wait for death from cancer. Other things will be looked at in secondary endpoints. And we'll be looking at cancer mortality within 5 to 6 years of randomization. We'll look at the cumulative number of cancers in individuals whose baseline test was positive. And we'll be looking at cancer mortality in those whose baseline test was positive as well as a number of safety type endpoints. So when you're designing trials, particularly in screening and prevention, you need to think, what's your key question? How should you design the study to answer that question? And remember not to try and show effectiveness until you've shown an efficacy. Thank you very much. I'm happy to take questions.
Thank you so much, Peter. I would appreciate if you turn your cameras on. A fascinating talk, very interesting to see how prevention trials are fundamentally different from interventional trials, and what we try to impose in interventional research does not really seem to apply to screening studies. So I look forward to your questions. As always, you can raise your arm through Zoom or on a screen if I can see you. So who wants to go first?
I've got a quick question.
Go ahead.
Well, I've got a particular question. Yes, I would like to say as well that I was fascinated by the talk, which was very, I felt almost very revolutionary to me. Yeah, and I struggled to keep pace, so dense, and I was almost breathless, and I really have to watch it again because it was fascinating. But I stopped a little bit on how we were looking at really the impact of the concealment of allocation and the blinding on the trials, whether it's so critical as we are used to think it is, and how there was this trial attempting to prove that whether it has an effect or not. But the problem I see with this is that we are trying to prove whether there's something not happening in here. So it's almost, we saw that there was no evidence of an effect, but then do we have, it's not the evidence that there's no effect, there's not the evidence. So we've got that conundrum here almost, don't we? And in fact, I know that some other academics, like to name one, say Peter Getke, he's been really looking at HPV vaccinations, and he's criticized that these are not compared to a control arms with their solvents alone. So all of this was in my head, and I'd just like to hear your views on how we could go about this.
Yeah, so on your first thing, yeah, it's very interesting. So what we had argued was it was because we were looking at all-cause mortality that there was no issue of subjectivity of analysis. And we actually always wanted to have a subgroup that would be placebo-controlled for looking at the effect on infections, because whether infections are recorded, upper respiratory infections, which is one of the endpoints we're particularly interested in, I think is very subjective. Not necessarily whether you have an infection, but whether it gets recorded in the GP notes depends on the patient and the GP. And so when we were going to look at that subjective outcome, we were only going to do that in a subgroup that was placebo-controlled. But your other issue is precisely the problem we had. We had not agreed between the four of us how we were going to interpret the results beforehand. So Julian and I took it for granted that because of the disadvantages of doing, of using a placebo, unless you found an advantage in something, either that it was going to, and so yeah, the other people were very worried that it would lead to a lot of contamination amongst people randomized to control. They'd go off and buy vitamin D, or that people would drop out and not want to take part in the study. So because we didn't see that, we said, well, let's save the money. And they were saying, no, you haven't shown that it was better. And we hadn't incorporated in a cost effectiveness analysis to say, if there's this cost saving and then you haven't got any harm. So they said, until we prove that it's better, you need to keep going with the placebo control. So the big trial that we wanted to do never happened. Finally, in terms of HPV testing, I think that Peter Gertcher just doesn't like big pharma, and he doesn't like HPV testing. So his problem is that the randomized controlled trials are randomized against vector. If you didn't do that, it wouldn't have been blinded. But because you did that, it means that lots of people had local inflammatory reactions to the vaccine, which always happens. How often that happened is recorded, but it's not true that you can't say, oh, well, there was no increase in local reactions because the people in the control arm had local reactions. So, to criticize the whole thing, we now have data which we've submitted for publication, but I can give you the rough result, which shows that there has been more than an 80% reduction in invasive cervical cancer in England in the cohorts that have been vaccinated. So this is amazing news. I can't give you details because it's under peer review at the moment, but the vaccine really does work. And for someone to try and stop it on the grounds that you haven't recorded properly how many people have a sore arm for the next 24 hours or 48 hours seems to me crazy. It's very clear what those reactions are. And I think that was part of the reason why he was fired from the Cochrane Collaborative, because they felt that he went around that in such a vast way. But I don't know the details really, but I haven't seen a good argument. They were placebo-controlled trials, but the placebo included adjuvant, and so that means that you can't look at local reaction because the adjuvant causes local reaction.
Yeah. Thank you for that. No, I do share your views that he placed a lot of emphasis on local reactions that we didn't see as relevant. Thank you.
Thank you. Emma, go ahead.
Hi. Thank you. It was a very interesting talk. I have a quick question about your vitamin D example. Do you have any examples that are similar where placebo didn't really matter when it came to a more immediate, possibly life-threatening intervention? For example, there was an old clinical trial in Canada where randomization to mammography was tampered with because people felt very strongly that mammography might prevent deaths, while vitamin D is sort of a nutritional thing.
I think the issue there is sort of concealment of allocation. It is possible that if people had really strong, there's two things that are relevant. One is what the availability of the intervention is if you've been randomized to control. So in many studies, there's no way the patient will be able to get hold of that intervention. So if they know immediately afterwards they're not getting it, that's so much. I think there are issues in terms of how difficult it is to conceal. I'm not a fan of sham operations in order to keep blinding. We had a study in rheumatoid arthritis, and the schedule of the drugs was different. And we felt it was unreasonable to make people to come in for an extra 4 infusions that would have been saline infusions in order to blind which treatment they'd had. It wasn't placebo controlled, it was controlled between 2 different drugs, both of which were used. So I think undoubtedly there are very strong placebo effects in some trials. And so if the endpoints you're interested in are likely to be affected by placebo, then I think you need to look at it. And I did have an example I took out where there was a nocebo effect. So what we found was that if you looked at the people who quit taking the intervention, the majority of people in the control arm who stopped taking their placebo was because they had symptoms that they were told could be a symptom of the drug that was being used in the trial. So actually, if you're told that, you assume that if you get that symptom, it's caused by the drug. And so their reaction was, I better stop taking my pills. And that's happened. So I certainly think that you need a good reason not to use a placebo. But where you've got a off-patent drug so that the cost of manufacturing the placebo is huge, and you are using a robust non-objective endpoint rather than a subjective endpoint, I think there's a question of whether you need to do a placebo control.
Thank you. Lydia, did you want to go next? You're muted. Okay.
Yeah, no, sorry. I didn't.
Okay. Anyone else? Any further questions for Peter? I have a fundamental methodological question for you. I think I just wonder if there are any publications out there in terms of methodological approaches towards interventional versus screening trials, because I think you made very eye-opening statements today, which are clear because, of course, for screening prevention trials, we're talking about completely different costs, completely different timelines, completely different objectives. Then when we try to establish an efficacy of a new drug for registration. So, but other comparative papers looking at that to guide clinical trial design?
Maybe, but I can't think of any off my head. So there are papers comparing different designs for screening trials, for instance. There's a paper by, I think, Duffy and Smith comparing different ways of analyzing trials of screening, illustrated with breast screening in the general medical screening. There are papers explaining the design of most of the major screening and chemoprevention trials. But I don't know, I can't think of any which are explicitly comparing treatment trials to prevention or screening trials.
Mm-hmm. Thank you. Perhaps a room for a PhD student to explore. Okay. Any other comments, questions for Peter? Then I have another question. Sorry for taking the floor, but currently, well, obviously screening has been under question, under fire for from different groups and for a lot of good reasons. We're being in the center of it, being involved in designing these trials. How do you take the criticism that was thrown towards screening programs that have been implemented that have cost amazing amount of money to society, which resulted in quite a few, let's say, probably wrong practices. And at the same time, we have screening programs which were extremely life-saving and very important for us as the society, and thank God we have them. So, and with screening, reversing something takes decades. It's very expensive. What is your personal position on this? In a sense, would you say that we should have done better trials, we should have made better decisions, or maybe it wasn't possible? Is there anything we can do for the future, designing better trials to stop implementing programs which should not take place and to implement programs which should take place?
There's definitely things we can do better. Cervical screening was introduced without a randomized controlled trial. It's actually one of the less controversial forms of cancer screening. And it wasn't that difficult to persuade the government or the NHS to stop screening 20 to 24-year-old women. It was extremely controversial, and I would say probably at least as controversial as the people who were opposed to withdrawing screening were at least as vocal and probably more numerous than the ones who were opposed to screening. I don't think that any of the screening programs that have been introduced in the UK have been a mistake. I think they have all led to greater benefits than harms by a considerable extent. They could have been introduced better. I think the information given about screening was poor to begin with and has improved dramatically over time. But there are complicated issues about how much information should be given and when. And some of that is to do with inequalities in society, that the way people react to information about harms and benefits is actually quite different. And it's been shown that if you add more information about the harms of screening, it tends to make no difference to the people who are wealthier and more highly educated, and a big difference to the people who are more deprived and with little education. And that's partly because of this issue of being able to, having the luxury of being able to plan for the future. The harms of screening tend to be immediate and the benefits are long-term. And so if your perspective is just how you're going to manage till the end of the week, then screening doesn't seem to be a good idea. So I think we need to think about how to do that. Mostly from our research, certainly in cervical screening, most women who haven't been screened, it's not a conscious decision that they've weighed up the pros and cons and they don't want to be screened. It's they haven't got around to it yet, or they find it uncomfortable or embarrassing, or it's not that they think, oh, actually. So it's quite different. I think we should be learning from COVID-19 vaccination. I mean, there's this huge issue about how people interpret risk, how they respond to risk, and you know, for my own circle of friends, people last July saying there's no way I'm going to have a vaccine, who were all rushing to get it in January or February, as soon as they could get hold of it. And so, yeah, the way people react in Japan, there is virtually no HPV screening because there was bad publicity about it early on and no one wants it. So not screening, HPV vaccination. So we do need to evaluate things rigorously. I think it's appropriate that it's regulated and that we don't allow huge amounts of unregulated screening to happen. In fact, lots of screening is available privately. Ovarian screening. I think there are a lot of people who still think that ovarian screening must work and they don't understand why it hasn't. But the UK CTOX results were pretty clear. This did not work. And so we should not have a screening program. We have to continuously look at things. But the issues are always that it's a public health intervention. The majority of people will not benefit from it. But by giving an intervention to the whole population, we can have a dramatic effect on the health of the population as a whole. And it's a complex thing, but having multi-cancer tests available now, and the GRAIL test is the first to be evaluated, does offer the hope of revolutionizing screening, because it means that one screen will be looking for all types of cancer. And the other thing which I think has to happen is, if we're doing site-specific screening, we need to tailor it to the risk. And that would mean doing more intensive screening for people who are at high risk, but also less intensive screening for people who are at lower risk. And doing that in a way that people are happy with. There is a possibility that people will feel that they're entitled to screening every 3 years. And if that's being taken away and they're only being offered screening every 6 years, that's not fair. So needing to explain very carefully that you don't need to be screened more often because you're at low risk.
Thank you. Any final questions?
The cervical smear screen, if you get a negative HPV result, and I think John Hickman and I recently tuned in earlier this year to a sort of Cancer Research UK series that we were doing on early diagnosis and screening. They were talking about the 3 years versus the 5 years. And they were suggesting that, of course, women who had been typically used to having a cervical test every 3 years, and now it's been pushed to every 5 years, they actually got slightly concerned by that, because they suddenly thought, well, hang on a minute, maybe it won't pick up cancers, you know, in that 2 year extra interval that's being missed. Interestingly, and purely by chance, I've actually just had an invitation for a screen and had one recently. It was negative, but I'm still indicated in my results letter as coming back 3 years' time to have a repeat, you know, screen. It's not 5 years. Is that because for some people that differential between 3 and 5 hasn't reached clinical practice yet? I just wondered what your thoughts were on that, Peter.
So, starting at the end of your question, I believe it's because of COVID-19 causing issues, and they're waiting for a new computer system to come into place to change. But I think that the decision has been made that it will change to 5 years. And I don't think there's any safety concerns. I think the safety concern is with the current computer system, which was written in the 1980s, so prehistoric by computing standards, whether it could cope with suddenly changing the interval that's being used. So they're waiting for the new system, which I think will come online later this year. So
that's reassuring to know. I think the only trouble is if women have received many thousands of them letters suggesting that their next test is due in 3 years, and then maybe because of a computer catch-up problem, actually in reality they didn't need it for 5, but that's not communicated appropriately. I can then see an example where harm could be caused psychologically, because they're now believing that they're having a test 2 years later than they should be, and they might be panicking that maybe something will go undetected. Do you see what I mean? I'm just saying that's something to perhaps for...
So on the one side, the impact of extending the interval, my colleague Jo Waller has done a lot. She published quite recently on looking at the women's attitudes to that. And it's clear there needs to be some careful communication about why the interval is being extended, and to make it absolutely clear that it's because the risk of developing cancer in the intervening time is so low and it's not thought that there's any real benefit in screening women more often. It's not a cost-saving exercise. It's done because it's extremely safe. The other issue I haven't thought about before, and I'll talk to Jo about, it happened once before. So when there was a time when it took up to 3 months to get your cervical screening results. And it was agreed this was totally unacceptable. And there was a move, and they now get results within 2 weeks to the vast majority of women. I think the standard is to get 98% of results within 2 weeks. When that first happened, when that first happened, anecdotally, I was told of a woman who had been told, oh, it'll probably take 10 to 12 weeks before you hear. And she heard in 10 days, and she was told her test was negative, but she panicked. She said, there must be some reason why they rushed my test result through. What's going on? So I do wonder whether there may be some women who worry, why am I being seen after 3 years when other people are being seen after 5 years? So I will talk to the behavioral scientists who I work with and make sure that there is information about that available to say that this is just, if you were screened before this date, then the 3-year rule still applied, and we won't be changing that retrospectively. If we told you would seen you at 3 years, that's when you'll be seen. Whereas if you're seen after this date, then it'll be 5 years.
I think that's a really good idea, because I think, and even if they were to receive perhaps further down the line a sort of information leaflet or something to explain things to them, so that even though that 3-year thing is honoured, if that was what was promised, maybe to kind of let them know that actually, the 5-year thing is not then going to be unexpected sort of thing, and it isn't to do with, as you say, cost savings, but because it's so sort of clear cut safe and low risk when you have your negative result, that it's actually potentially nicer for the patient as well, because they don't have to have this invasive intervention every 3 years but every 5. I was just raising it because I do think perhaps the way in which, when I listened to the CRUK talk, that there was quite a lot of feedback from the women in the study, and I could understand why some of them might have been a little bit confused, because they've had years and years of, you've got to have it up every 3 years, and suddenly it's 5, and if you don't have adequate communication, they might have sort of wrongly assumed it's for nefarious reasons, if you see what I mean.
No, and I'm worried about what's going to happen with HPV vaccination, because it really makes no sense to continue screening women with the same frequency if they've been vaccinated, particularly if they were vaccinated when they were young. And yet, the current recommendation is you should be screened exactly the same way, because that's the policy, and the policy hasn't changed. But at some point it will change, and it will change quite dramatically. And communicating that will be a challenge, I'm sure.
Thank you.
Peter, thank you so much. We're out of time. Greatly appreciate your talk, for finding time to meet with us, for sharing your knowledge. So thank you so much. And on this note, I'll close the meeting. So goodbye, everyone. We'll see you in 2 weeks.
Thank you very much.
Bye.
Bye. Thank you. Bye-bye.
Bye.